Okay, so imagine this. You're rushing someone to the hospital. Every second feels like forever. And your loved one, they're struggling to breathe, skin's clammy and cold, and there's just this panic in the air.
Yeah.
It's a heart attack, but it's more than that. It's cardiogenic shock, and that's a condition where the heart is just not pumping enough blood to keep the body going, so the clock is ticking. And today we are going to dive deep into this critical condition. Huge thanks to the London HeartbeatsZ Academy in the UK for the incredible research they've compiled on this topic. Make sure to follow us on Facebook, Instagram, Spotify, and YouTube so you don't miss out on future deep dives like this.
You're absolutely right. That sense of urgency is absolutely crucial. Because cardiogenic shock, or CS, it is a real race against time. It's like a car engine suddenly failing. Without that vital pump, everything starts to shut down.
So it's more than just a heart attack. It's a whole body crisis.
Exactly. A heart attack can trigger CS. But there are other culprits too, like infections or even problems with the heart valves. The key takeaway here is that in CS, the heart can't meet the body's demand for oxygen-rich blood, and that leads to a cascade of problems as organs start to fail.
Okay, so it's not like a single disease, but a syndrome with different paths leading to the same, dire outcome. Now, the research mentions two main types of CS, acute and acute on chronic. What's the difference and how does that impact the outlook?
So imagine two cars. One suffers a sudden catastrophic engine failure. That's acute CS, often caused by a massive heart attack, like being struck by lightning, sudden and devastating. The other car has been sputtering for a while, struggling to keep going, and then finally gives out. That's acute on chronic CS. Existing heart problems suddenly worsen and push the system over the edge. It's a bit like a slow burn that reaches a critical point.
So in both cases, the engine fails. But the speed and the context are different. And I'm guessing that impacts how doctors approach treatment.
Absolutely. Understanding the type of CS helps guide treatment decisions. But in both cases, time is of the essence. The faster we can intervene, the better the chances of survival.
Okay, that makes sense. Now, just how common is CS? Should the average person be worried?
Here's where the numbers get a bit concerning. CS accounts for a significant portion of ICU admissions, about 7 to 10%. And while the incidence of CS following a heart attack has, thankfully, decreased to about 2.8%, the one-year mortality rate for those patients remains alarmingly high, around 58%.
Wow, that's really significant. What about people with CS not related to a heart attack? Do they fare any better?
The data suggests their survival rate is slightly better, hovering around 36%, but it's crucial to remember that CS, regardless of the cause, is a serious condition. Early recognition and treatment are paramount.
Okay, so early detection is key. If someone suspects they or a loved one might be experiencing CS, what should they look for? And how do doctors go about making the diagnosis?
It often starts with a sense of something being terribly wrong. Look for signs like cold extremities, low urine output, confusion, and of course the telltale sign of low blood pressure. Doctors will conduct a thorough physical exam, checking for these signs, and then move on to basic tests like an electrocardiogram or EKG, which measures the heart's electrical activity.
So like listening to the heart's rhythm to see if it's out of sync. And I'm guessing blood work plays a role too.
Absolutely. Blood tests, especially checking lactate levels, can provide valuable clues. Lactate is a substance that builds up in the blood when the body's tissues aren't getting enough oxygen. High levels are like a red flag, signaling that the body's in distress.
So it's like a distress signal from the cells themselves saying, hey, we're not getting enough oxygen here. Now, I know imaging is crucial in diagnosing heart problems. What role does it play in CS?
Think of it like getting a live feed of the heart's performance. One of the most important imaging tests is an echocardiogram. Specifically, a transthoracic echocardiogram, or TTE, uses sound waves to create real-time images of the heart, allowing doctors to assess how well it's pumping, identify any valve problems, and check for fluid buildup around the heart.
So it's like having a tiny camera inside the heart, giving doctors a front row seat to the action.
Exactly. It's a powerful tool that helps us understand the severity of the problem and guide treatment decisions.
Now, for severe cases, are there any other advanced monitoring tools that doctors use?
Yes. Sometimes we use a pulmonary artery catheter or a PAC. It's a thin, flexible tube that's threaded through a vein into the heart and pulmonary artery. This allows us to directly measure the pressure and oxygen levels in the heart and lungs, giving us a very detailed picture of what's happening hemodynamically.
So it's like getting real-time data from the heart's control center.
You could say that. It's a valuable tool, but it's reserved for the most critical cases. Now, something that really stood out to me in the research was the idea of CS phenotypes. categorizing patients into different groups based on how the shock is affecting their body. Could you explain why this is important?
Yeah, that's a crucial point. It's not just about recognizing that the heart is failing, but understanding which other organs are taking the biggest hit and how that influences treatment. It's like knowing not just that the engine is failing, but which parts of the car are getting damaged because of it.
Exactly, and it helps us tailor treatment to the individual patient's needs. The research outlines three main phenotypes: not congested, cardiorenal, and cardiometabolic. Let's break those down, shall we?
Absolutely. Let's start with not congested.
Hmm.
What does that tell us about the patient's condition?
So these patients are in the early stages of CS. Their heart is struggling, but other organs haven't been severely affected yet. They might have a lower heart rate than you'd expect, and their fluid pressures are relatively normal. It's a bit like the engine sputtering. But the car can still limp along for a short distance.
So it's like a warning light is flashing, but the engine hasn't completely seized up.
Precisely. Early intervention at this stage is critical. Now let's move on to the cardiorenal phenotype. As the name suggests, this is where the kidneys are getting caught in the crossfire.
So in this case, it's not just the heart that's in trouble, but the kidneys are starting to fail as well.
That's right. We see this more often in older patients who might already have some degree of kidney dysfunction. Remember, the kidneys are responsible for filtering waste products from the blood, and when they're not getting enough blood flow, they can't do their job properly. This can lead to a buildup of toxins in the body, further complicating the situation.
So it's a double whammy. The heart's not pumping enough, and the kidneys can't filter the blood effectively. That sounds incredibly dangerous.
It is. Managing these patients requires a delicate balancing act. We need to support both the heart and the kidneys to prevent further damage.
Okay, so it's a more complex situation, requiring a more nuanced approach. Now, what about that third phenotype, cardiometabolic? What makes this one different?
This is the most worrisome phenotype. Remember how we talked about lactate being a distress signal from the cells? Well, in cardiometabolic CS, those signals are blaring. These patients have very high lactate levels, indicating that their tissues are starved for oxygen. And it's not just the kidneys that are affected. We often see multiple organ dysfunction, including liver problems.
So it's like the whole body is going into crisis mode.
Exactly.
Yeah.
The situation is dire, and these patients require the most aggressive treatment. Now, shifting gears a bit, let's talk about how doctors tackle this complex problem. The research highlights coronary artery revascularization as a game changer, particularly for heart attack-related CS.
So if a heart attack has triggered the shock, the first step is to open up that blocked artery.
Exactly. We need to restore blood flow to the heart muscle as quickly as possible. This usually means performing an emergency angioplasty, also known as a PCI. A thin tube with a balloon on the tip is inserted into the blocked artery, and the balloon is inflated to widen the passage and restore blood flow.
It's like using a tiny plumber to clear a clog in the heart's plumbing.
That's a great analogy. Now, a landmark study called the SHOC trial showed that doing this early, within the first few hours of the heart attack, significantly improves long-term survival for these patients.
So it's a race against time to get that artery open.
Absolutely. Every minute counts. Now, here's where it gets interesting. For years, the thinking was that if someone had multiple blocked arteries, we should try to fix them all during the initial angioplasty.
That seems logical. Why wouldn't you want to address all the blockages while you're already in there?
It makes sense on the surface, right? But a groundbreaking study called Culprit Shock challenged that assumption. This large trial showed that focusing only on the culprit artery, the one directly responsible for the heart attack, during the initial angioplasty actually leads to better outcomes.
So sometimes less is more.
Exactly. It turns out that tackling all the blockages at once can overwhelm the system, especially when the heart is already in a fragile state.
It's almost counterintuitive,
Okay.
but the research clearly shows that focusing on the main problem first gives the best chance of recovery.
That's the beauty of scientific research. It constantly challenges our assumptions and helps
Yeah.
us refine our approach.
Okay, so we've talked about opening up that blocked artery.
Yeah.
What other critical interventions are used to manage CS?
Two key areas are managing arrhythmias and addressing any valvular problems. Arrhythmias are irregular heartbeats that can further compromise the heart's ability to pump effectively.
So it's like the heart's rhythm is offbeat, making it even harder to do its job.
Precisely. Restoring a normal rhythm, often with medications like amiodarone, is essential.
It's like getting the heart back in sync. Now, what about valvular problems? How do those contribute to CS?
The heart valves act like gates, controlling the flow of blood through the heart. If a valve is damaged or doesn't close properly, it can cause blood to leak backward. or obstruct blood flow, putting extra strain on the heart. This can push a heart that's already struggling over the edge into shock.
So it's like having a leaky valve in a water pump. It just can't function efficiently.
Exactly. Treatment for valve problems depends on which valve is affected and the severity of the problem. It could involve medications, surgery, or increasingly minimally invasive procedures like TAVR, which is a valve replacement done through a catheter.
So it's a tailored approach, just like with everything else in CS management. Now medications play a huge role in stabilizing these patients. Could you walk us through the types of drugs used and how they work?
We rely heavily on two classes of drugs, inotropes and vasopressors. Inotropes like dobutamine are like giving the heart a shot of espresso. They increase the heart's contractility or pumping force, giving it a much-needed boost.
So they help the heart muscle squeeze harder?
Exactly. Vasopressors, on the other hand, are like tightening up the plumbing. They constrict blood vessels to raise blood pressure, ensuring vital organs are getting enough blood flow. Norepinephrine is a commonly used vasopressor in CS.
So it's like squeezing the pipes to increase the pressure and force the blood to reach those vital organs. The research specifically mentioned two trials, SOP and Optima. What did those tell us about vasopressors?
Those trials were game changers in guiding our choice of vasopressors. They found that norepinephrine was generally safer and more effective than dopamine or epinephrine in most CS cases.
So it became the go-to drug for boosting blood pressure in these situations.
Exactly. Now let's talk about another major challenge in CS breathing difficulties. When the heart's not pumping effectively, it creates a backlog of blood in the lungs, making it hard to breathe.
It's like the lungs are drowning in blood.
That's a good way to put it. This fluid buildup in the lungs, called pulmonary edema, can be life-threatening.
So how do doctors help these patients breathe easier?
We have different levels of respiratory support, starting with non-invasive ventilation, or NIV. It involves delivering pressurized air through a mask, helping to open up the airways and improve oxygenation.
It's like giving the lungs a little extra help to do their job.
Exactly. NIV can be very effective in less severe cases. But if the patient's breathing is severely compromised, we might need to use invasive mechanical ventilation, or IMV. This involves placing a tube down the windpipe and using a machine to breathe for the patient.
So it's like putting the lungs on life support.
In a sense, yes. It allows the lungs to rest while the machine takes over the work of breathing.
Now, I noticed the research cautioned against using certain ventilation modes, like pressure support ventilation, or PSV in the acute phase of CS. Why is that?
PSV, while useful in other situations, can actually increase the workload on the heart in the acute phase of CS. Remember, we want to do everything we can to minimize the strain on the heart.
So it's like asking an exhausted marathon runner to sprint the last mile.
Exactly. We carefully choose ventilation modes that provide adequate oxygenation without overtaxing the heart.
Now, another complication we touched on earlier is acute kidney injury, or AKI. It's a bit unsettling that up to half of CS patients develop this.
It's a serious concern, and it highlights the interconnectedness of the body's systems. When the heart isn't pumping effectively, the kidneys are one of the first organs to suffer. They're not getting enough blood flow, which means they can't filter waste products properly.
So it's a vicious cycle. The heart affects the kidneys, and kidney problems can further worsen the heart's function.
Exactly. And that's why managing AKI in CS patients is so critical. We often use a gentler form of dialysis called continuous renal replacement therapy, or CRRT.
Why is CRRT preferred over traditional dialysis in these cases?
Think of it this way. Traditional dialysis is like doing laundry in a washing machine. It's a bit rough and tumble. CRRT, on the other hand, is like hand-washing delicate garments. It's a slower, gentler process that's less stressful on the body.
So it's all about minimizing stress on an already overwhelmed system. Now let's talk about a more cutting-edge aspect of treatment, mechanical circulatory support devices.
These devices have revolutionized the way we manage severe CS cases. They're essentially temporary bridges, helping the heart rest and recover.
We briefly mentioned Impella and VA ECMO earlier. Could you break down how these devices work and when they might be used?
Absolutely. Impella is a smaller, less invasive device that's placed directly into the heart through a catheter. It helps pump blood from the left ventricle, the heart's main pumping chamber, to the aorta, the large artery that distributes blood to the body.
Just like a little helper pump inside the heart itself, giving it a boost.
Precisely. Now, VA ECMO, or veno-arterial extracorporeal membrane oxygenation, is a bit more involved. It's a system that pumps blood outside of the body, bypassing both the heart and the lungs.
So it takes over the function of both those organs.
Exactly. Blood is drained from the body, oxygenated and filtered by a machine, and then pumped back in. This allows the heart and lungs to rest and hopefully recover.
It's like putting the heart and lungs on a temporary vacation while the machine does the work. That sounds pretty incredible.
It is a remarkable technology, but it's important to remember that it's not a cure-all. The research highlighted some of the ongoing debates surrounding the use of VA ECMO, especially in CS.
What are some of the key considerations when deciding whether or not to use VA ECMO in these cases?
The decision is complex and involves a careful weighing of the risks and benefits. While VA ECMO can be life-saving, it's a resource-intensive therapy with its own set of complications.
So it's not a decision taken lightly.
Absolutely not. It requires a multidisciplinary team approach involving cardiologists, intensivists, and surgeons to make the best decision for each individual patient.
It sounds like a lot of factors come into play. The severity of the shock, the patient's overall health, and the potential for complications.
Exactly. We also need to consider the ethical implications, especially in cases where the prognosis is poor.
So it's a balancing act between offering hope and utilizing resources wisely.
Precisely. And it underscores the importance of having open and honest discussions with patients and their families about the goals of care.
Welcome back to our deep dive into cardiogenic shock. Before we took a break, we were talking about some of the more cutting-edge treatments like Impella and VA ECMO, and how these technologies are really kind of changing the landscape of CS management. It's remarkable how far we've come in our ability to support the heart and other vital organs.
It really is, isn't it? But there's still so much we're learning about this complex condition. For instance, we've talked a lot about how CS affects the heart and kidneys, but we haven't really touched on its impact on the respiratory system.
Yeah, you're right. We know that breathing difficulties often go hand in hand with CS. I mean, it makes sense when you think about it. If the heart's struggling to pump, the lungs are going to feel the effects.
Exactly. And those effects can be pretty dramatic. When the heart isn't pumping efficiently, blood backs up in the lungs, causing fluid to leak into the air sacs. It's a condition called pulmonary edema, and it can make breathing incredibly difficult.
So it's almost like the lungs are drowning in fluid.
That's a good way to visualize it. And as you can imagine, this respiratory distress just makes everything worse. The body is starved for oxygen, so it tries to compensate by breathing faster, which ironically puts even more strain on the already weakened heart.
It's a vicious cycle. Heart struggling to pump, lungs filling with fluid, and the body desperately gasping for air. So how do doctors break this cycle and provide that much-needed respiratory support?
Well, the first line of defense is usually non-invasive ventilation, or NIV, remember how we talked about it earlier, as a way to support breathing without intubation.
Yeah, like giving the lungs a little extra help to do their job.
Exactly. NIV delivers pressurized air through a mask, helps to open up the airways and improve oxygenation. Can be very effective in the early stages of respiratory distress.
But what if NIV isn't enough to keep those oxygen levels up?
In more severe cases, we might need to move on to invasive mechanical ventilation, or IMV. This involves placing a breathing tube down the windpipe and using a machine to breathe for the patient.
So it's like putting the lungs on life support.
You could say that. Allows the lungs to rest while the machine does the work of breathing. Gives the body a chance to recover.
No, the research we reviewed cautioned against using certain ventilation modes, like pressure support ventilation or PSV, in the acute phase of CS. Why is that?
It's all about minimizing the strain on the heart. PSV, while effective in other situations, can actually increase the heart's workload, and that could potentially worsen the shock.
So it's like asking someone who's already run a marathon to sprint the last mile.
Exactly. We have to be very careful about how we manage ventilation in these delicate situations.
Now, beyond the immediate respiratory crisis, are there any long-term lung issues that CS patients might face?
One concern is the risk of pneumonia. Patients on mechanical ventilation are more susceptible to lung infections, so preventative measures are crucial. Things like good hand hygiene, oral care, and careful positioning.
So it's not just about getting them breathing again, but also protecting their lungs from further damage.
Precisely. And once they're off the ventilator, pulmonary rehabilitation can be really helpful in regaining lung strength and function.
So it's a holistic approach, addressing both the immediate crisis and the long-term health of the respiratory system. Now, throughout our deep dive, we focused a lot on the heart, lungs, and kidneys. But it's important to remember that CS affects virtually every organ in the body.
That's a really good point, because CS reduces blood flow throughout the body. Other vital organs, like the liver, brain, and intestines, can be damaged as well, and this can lead to a whole cascade of complications.
So it's truly a systemic illness that requires a multifaceted approach to management.
Exactly, and that's why treatment involves not only addressing the heart problem itself, but also providing supportive care to all those other organ systems that are affected.
Now, speaking of treatment, we've discussed a whole array of options, from medications to mechanical support devices. But is there a cure for cardiogenic shock?
Well, the answer is a bit complicated. CS isn't a single disease with a single cure. It's a syndrome, a complex interplay of problems stemming from heart failure. Our focus is on restoring blood flow, supporting those vital organs, and addressing the underlying cause of the shock.
So it's more about managing the crisis and preventing further damage than finding a magic bullet.
Precisely. And the success of treatment depends on so many factors: the severity of the shock, the underlying cause, the patient's overall health, and the timely delivery of appropriate therapies.
It's like a puzzle where all the pieces have to fit just right to get a positive outcome.
That's a great analogy. And while we've made incredible strides in managing CS, the mortality rate remains high.
It's a sobering reminder of just how serious this condition is.
It is, but it also fuels our drive to continue researching and innovating, to find better ways to diagnose, treat, and ultimately prevent cardiogenic shock.
Well, this deep dive has been incredibly informative, maybe a little overwhelming at times, but it's clear that cardiogenic shock is a complex and challenging condition. But it's also inspiring to see how medical science is constantly pushing the boundaries to find new solutions.
I agree. And one of the most important takeaways is that early recognition and treatment are key. The faster we can intervene, the better the chances of a positive outcome.
So knowing the signs and symptoms of CS could literally save a life. And if you're ever in doubt, it's always best to err on the side of caution and seek medical attention.
Absolutely. It's better to be safe than sorry.
Well, on that note, I think we've covered just about everything there is to know about cardiogenic shock, at least for now. A huge thanks to you for sharing your expertise with us today. It's been a truly enlightening conversation.
The pleasure was all mine. And thanks to the London HeartbeatsZ Academy for compiling such a comprehensive body of research on this important topic.
Yes, their work is invaluable. And to our listeners, thank you for joining us on this deep dive into the world of cardiogenic shock. We hope you found it informative and engaging. Don't forget to subscribe to our channels on Facebook, Instagram, Spotify, and YouTube to stay up to date on all our future deep dives. Until next time, stay curious, stay informed, and stay healthy.